Thank you so much for the kind invitation, Gayatri. At the outset, I would like to thank AIOC for this opportunity. My topic for today is worth a PhD, and I'm giving 10 minutes to it. So please excuse whatever I have missed out. The topic is bug versus drug overview of microbial keratitis. We will be approaching microbial keratitis in a more practical fashion, and these are the few points I'll be covering. So when a patient of microbial keratitis comes to my clinic, this is a rough sort of a thought process that goes through my mind. Whether the patient is on treatment, if the patient is on treatment, do you feel that the patient is responding to treatment? This could be a mixture of from the history, from the look of the infiltrate, etc. If you feel the patient is improving, probably rationalize the medication he or she is using, counsel the patient, and follow up. If the patient is not on treatment or is not responding to treatment, then corneal scraping needs to be done at that point in time. If the patient has an infiltrate which is long standing, not responding to treatment, is on a cocktail of medications, then probably you would want to give a drug holiday as well before doing a corneal scraping. The corneal scraping may most likely show fungal keratitis for the region I come from, or in a rare case, a bacterial keratitis. And you start appropriate therapy. You see the response for treatment. Sometimes it worsens and it may require a therapeutic keratoplasty. But is this comprehensive enough? Because I've realized over a period of time that this is a big, it's like a sieve. A lot of nuance is lost in this algorithm, and I would today like to focus on the nuances of microbial keratitis management. So, a little bit of an overview of fungal keratitis. We all know that trauma with vegetative matter, especially in a agrarian population like ours, is very common. Uncontrolled diabetes is sometimes missed because of it. When things are routine, they get missed. It has to be a part of your protocol so that you remember to use that question. Chronic dry eyes or any local or systemic immunosuppression, chronic steroid use, that can also cause fungal keratitis. Treatment, of course, we have the three pillars of fungal keratitis management: natamycin, voriconazole, amphotericin B. Oral ketoconazole and voriconazole will require LFT monitoring, and voriconazole and amphotericin B require reconstitution with cold chain management, needs to be taken care of. So this is a small example of how sometimes in routine things get missed. It's a small infiltrate, it's not something alarming. This patient had undergone iron foreign body removal elsewhere, and all of us have removed scores of iron foreign bodies. How many of them end up with an infection like this with DM folds and an infiltrate? And I mean, it's quite rare, right? When we checked the diabetic status of this patient, it was 280 mg per DL RBS. So, a small infiltrate where it is not expected is probably the first clue to look for other reasons for this infiltration. Bacterial keratitis in my part of the world is a little rare because contact lens use is a little rare. But in contact lens related keratitis, we see very typical coin shaped infiltrates, a little central to paracentral. They respond usually well to broad spectrum antibiotics if we are lucky. Mixed infections are seen often. Gram-negative keratitis tends to be more common in eyes with ocular comorbidities like chronic ocular surface disease, severe dry eye, or any other long-standing treatment like glaucoma. Pseudomonas keratitis is more likely if there are rapid corneal melts, the eye is melting in front of your eyes, definitely will need a culture sensitivity backup and early therapeutic keratoplasty. But the bug is key, right? If you don't know what you're treating, your treatment will most likely be an arrow in the dark. So, this is one of the cases that we have handled. It's a 40-year-old woman, history of pain, irritation since 2 months on broad spectrum antibiotics, antifungals, cocktail therapy is going on. On evaluation, there's a scanty infiltrate. There is nearly no stromal involvement. There is no hypopion, but there is intense pain. Something that has been on the eye for 2 months, you would expect that by now it would have eaten up the cornea. But it hasn't, right? Why? So we started her on therapeutic dose of antimicrobials. The pain went off first, and she overall healed quickly. So what was it that we did, and what helped? So it was a nocardia keratitis. It was not a very classical wheel wreath-like presentation, but then pain, intense pain, which is not commensurate with the amount of infiltrate, the lack of stromal invasion despite it being a long-standing infiltrate. All these things point towards a unusual microbe, and therefore has to be thought of in terms of nocardia, acanthamoeba, etc. It healed well with amikacin eye drops, and it usually responds beautifully. Exposure to soil is again common with both nocardia and fungal keratitis. So the clinical presentation and how your infiltrate appears is also something that needs to be taken into account while looking at the diagnosis. Here's another case of scanty infiltrates. So these two had intense pain. Is it the same thing? There was an additional finding here. We compare and contrast these cases. There is radial perineuritis in the second case, which is the clincher here, and which turned out to be acanthamoeba. So scanty infiltrates always need to ring a bell in your mind that probably not a usual fungal or a bacterial keratitis. There are other unusual infiltrates which need to be taken care of. Adjunct procedures like ocular surface staining in something like this, where the patient was sent is for an opinion of corneal transplant post cataract surgery. On staining the eye, we see that it's a geographic ulcer due to chronic steroid use. Or something like this, which is an epithelial lesion. Probably, if you don't look at it very closely, you might not be able to see it so beautifully. This is epithelial microsporidiosis. I realize that tissue adhesive bandage contact lens really helps. Basically, why do we use tissue adhesive? Because we want to prevent perforations, we want to get some time to deal with the infiltrate which has started responding, but there is an area of small perforation. You might even have to do some heroics on the slit lamp, like form the AC and with air, or etc. And you want to avoid taking the patient to the OT, you might want to do that, but that is helped by the tissue adhesive a lot. There is a certain amount of antibacterial activity that the tissue adhesive has, but that's something that is anecdotal. What do you do with large infiltrates? Now, these are all large infiltrates that we have seen and treated. This is the presentation versus what we ended up with. And what is common amongst all? These were all culture negative. They were all referred for a therapeutic keratoplasty, and they responded to antiviral treatment followed by topical steroids. But when you do something this risky, you have to remember that there has to be a culture negative report with you. You have to be sure, you should have scraped it, you should be sure of the microbiologist who has reported it, and then only start something where you are starting a steroid in a large infiltrate. Special situations like intracameral injections are very helpful at times. This was a case of ours which required a therapeutic keratoplasty. All was well till first 14 days, and then there was an early recurrence from the 10 o'clock region at the graft-host junction. This patient also will develop pain suddenly, and pain after therapeutic keratoplasty, even if you have not started steroids, is indicative of a recurrence. This is how we finally ended up with the patient after 5 intracameral injections of voriconazole. And so we go back to our microbial keratitis algorithm we started out with, but we also acknowledge that it was not complete. So where do we have the plugs that we can fill the holes with? So if your patient is responding to treatment and there is a small perforation, probably a TABCL with ACD formation helps. There are therapeutic keratoplasty should be supported by intracameral intravitreal injections at times. Corneal scraping when there is no organism seen on culture probably could be viral. Don't forget stromal necrotizing keratitis. Unusual organisms are something that need to be at the back of our mind while treating these patients. And I thank you for your kind patience. Thank you.